Okay, welcome everybody to our final session for the conference. Thanks for staying with us. We are excited to bring our GP stream and the primary care stream together for this important panel discussion on First Nations health, the role of primary care. My name's Matt Dixon and I'm Director of First Nations Health and COVID-19 for Western Victoria Primary Health Network. I'm joining you from Gadabanood country and I pay respects to traditional owners of all of the lands and waterways we're joining from. I also pay respects to elders past and present, as well as all First Nations people who are in this session. Firstly, we'd like to thank Western Victoria Regional Training Hub for generously supporting this session. Please remember to pop over to the virtual sponsors lounge and browse through the individual pages over there. If you have any questions for any of the panellists that we have today, please type your question into the Q&A box, and we really encourage you to ask some questions. There are no bad questions, so do feel free to go for it. We're going to start with a pre-recorded chat that I had earlier in the week with Professor Peter O'Mara. Professor O'Mara is on the board of the RACGP and he's chair of the RACGP Aboriginal and Torres Strait Islander Health. He's Professor of Thuru Indigenous Health Unit at the University of Newcastle. He also works at 2 Aboriginal medical services as a GP, so he still has those boots on the ground at the community level, which is wonderful. So after we've heard from Professor O'Mara, we'll be hearing from Tanya Dalton, who's chair of the Indigenous Psychologists Association and a First Nations psychologist. Finally, then, we're going to be joined by Cherie Lowe, who is First Nations leader of the Social and Emotional Wellbeing Centre of Excellence at the Victorian Aboriginal Community Controlled Health Organisation, more commonly referred to as VACCHO. These 3 First Nations contributors are going to explore some of the current systemic issues and challenges being addressed to achieve greater health equity and promote holistic and person-centred healthcare for First Nations peoples in Western Victoria and beyond. So we're now going to go over to Professor O'Mara and look at that pre-record 20-minute session. Come with. Okay, so Professor Peter O'Mara, welcome. It's great to have this opportunity to have a bit of a chat with you and hear from you. So just for the audience here, Professor Peter O'Mara is on the board of the RACGP. He's the chair of RACGP Aboriginal and Torres Strait Islander Health, and he's the Professor of Thuru Indigenous Health Unit at the University of Newcastle. He works at 2 Aboriginal medical services as a GP, so he's doing a lot of that amazing academic work, and he's still got his boots on the ground as a GP. That's pretty impressive. Welcome, Peter.
Thanks, Matt. Thank you very much. Thanks for the opportunity.
Oh, lovely to have you here. So, Peter, I think at the moment I'll just throw to you for starters for you to tell us a little bit more about yourself and where you're from and, what you want to sort of impart to the group here, GPs, practice nurses, some of the admin reception staff in Western Victoria. So over to you, Peter.
Thank you. So first of all, I'd like to acknowledge the traditional owners of all the lands that we gather from today. Today I'm here where I actually live on Worimi and Biripi country, and I work for both Worimi and Biripi people too, so I'm very, very privileged to live on their lands. So I'm a Wiradjuri man. Northeast Wiradjuri country is the land of my family. From Mudgee, Ralston, Glen Davis, down to Lithgow, Kapiti Valley, and most of the Wollamai National Park is my family's lands. So I mostly grew up in the Hunter Valley, not far from Cessnock and Newcastle. And when I was at school, I think the best job I could hope to have got was a job in the coal mines. They were a secure job that paid well, and that was something that I sort of esteemed too, and had got a job in the mines. And I injured my back in a car accident and couldn't do the work that I was doing, so I had to look for something else. And I tried a few things. I tried to go back to sort of security and bouncing and that kind of stuff, but standing at the front of pubs and clubs for a long time was quite challenging. So then I thought I'm going to have to use my brain. So I done a matriculation course and got into the University of Newcastle. I got into psychology and was studying psychology and absolutely loved it. The thought of being one-on-one with someone and trying to make a positive influence in their life was really inspiring for me. So I was really enjoying that. And I was at home one day studying for exams, And I'd been studying all morning. My eyes were red and sore, so I made some lunch, put the television on, and the Ray Martin show back then, the midday show was on back in those days. Most people probably won't even remember what that is. And he was interviewing the first two Aboriginal doctors to graduate from the University of Newcastle. It was Lewis Peachy and Sandy Eads. And I'd seen him interviewing these doctors, and I just thought, wow, they're just normal. First of all, it was like, wow, they're Aboriginal doctors. I couldn't believe it. I was really taken back in an overwhelming positive way. And then as they were being interviewed, I thought, they're just normal people. They're just like me. Maybe I could give that a shot. And I think, although I love the psychology and I do more mental health than any other GP I know, but probably most GPs would say that too, because it's a large part of what we do, and I really enjoy that. I just wanted more of the science and stuff as well, and to broaden what I was doing. So I took that opportunity and was blessed to have the opportunity to get into medicine, and then studied through and done internship and so forth. And then it's almost like overnight you're on one side of the lectern and then you're on the other side, because I started working for the university about 16 years ago in a full-time capacity, and about 2 years before that I just tried it for 12 months and really enjoyed that as well. So that was my journey. And it's interesting that, you know, when we talk to a lot of our medical people, our Aboriginal Torres Strait Islander doctors and medical students, you know, the majority of them, it wasn't until they met another medical student or another doctor or seen that they thought we could do that as well. And so, you know, I did really well at school in science, but I never considered the possibility of doing anything like medicine. I always thought that was for rich people and doctors' kids, so I didn't even give it a shot.
All right. If you can't see it, you can't be it.
That's right. That's right. But there is such a sense of really still being overwhelmed by it, you know, particularly on clinical days. Sometimes I drive to work in the morning and think, I can't believe I'm a doctor. I can't believe I'm going to the opportunity to sit with people and try and make a positive difference in their life. So, you know, sometimes we get tired and we're working hard and all that kind of stuff, but I think sometimes you just step back and reflect on that and realize what a great opportunity it is for people to take you into the deepest parts of their lives. You know, some people are almost strangers and they still do that with us. It's an amazing opportunity.
Yeah, fantastic. I'm interested in asking you about, you know, as a Aboriginal person who's a doctor, that obviously creates a wonderful opportunity for probably a high level of cultural safety for, you know, First Nations patients who come to you. And I know that, you know, there's a lot of efforts, investment that has gone in for a long time to increasing that First Nations health workforce and GPs. And, you know, some of it's slow going, but it's heading in the right direction, perhaps a lot slower than we might like. But I'm interested in a little bit about, say for a GP who is, or a practice nurse who is not First Nations, I'm interested in some of your sort of tips and tricks and sort of advice about how they might try to make their practice and their service, both the, you know, the practice as it's given, you know, the service as it's given, and the practice, the bricks and mortar, the space, less culturally unsafe. I suppose I'm being careful with those words, because I think pure, you know, perfect cultural safety is a bit of a holy grail, and I think it'd be pretty presumptuous of you know, a lot of non-First Nations health service to claim they can provide that, but they can certainly make the service more culturally safe. Could you tell us a bit about your thoughts there?
Well, I suppose the first thing that I think of is that, sure, as an Indigenous doctor, when I'm with patients, and that there is a natural connection and a trust. And I was just sharing a story. I just spoke to a gentleman that I hadn't spoken to for probably about 10 years, and reminded me when I was a medical student, I went to Broken Hill to do a placement and asked, could I go to Wilcannia, which is largely an Aboriginal community, for at least a couple of days. And they said, yeah, you can. And when I got there, they were telling me about this old gentleman who'd been having, they thought he was having trouble with his heart. And he wouldn't come down and see the doctors. And so then I got someone to check with him. It was okay if I come around and have a bit of a yarn to him. So I sat on his veranda, probably had 5 cups of tea with him. And he said, okay, young fella, you want me to come down to the clinic, don't you? I said, if you don't mind. And, you know, with the instruction from the doctors from the RFDS, we've done the ECGs and pulled bloods from him and everything, and got him in touch with people, including the doctors. So that was when I first realised the power and the connection and what that does. But then I also reflect on the other side of that, is that in a lot of the communities that I do work for and have worked for, they've got non-Indigenous nurses and practice managers and GPs who the community wouldn't trade for the world because they're really good at what they do.
Yeah.
And so then how, if you're someone who wants to be that, how do you get to that point? I think, doing courses when you can, but also not being scared to have those yarns and to ask those questions. I think a lot of people worry about, oh, what if I say this and it's offensive? But and this is what I tell the students when I teach too. Like, if you ask questions in a genuine, respectful way, you're not going to be met with anything negative, because people actually appreciate you being interested in them in a respectful way, regardless of who they are. So I think they're the first steps. The people that I've seen do it really well, they're just good people overall. And I think that's one of the things that I've noticed about, thankfully I've been involved with teaching registrars and nurses and medical students that over many years in the Aboriginal health space. And what I've seen is that when we teach people when we teach people to do Aboriginal and Torres Strait Islander health well, they're just better practitioners overall, So there are practitioners who will come to Aboriginal health who are just, the shining lights because they're just good at what they do. And there are people who we can help polish their skills to make them even better at what they do. And a large part of it is about trying to look at the world through someone else's lens.
Yeah.
And not being judgmental and those kinds of things. And for example, I was just talking to a group of people last week, and we got talking about having maybe international medical graduates as part of this conversation and those kinds of things. And someone sort of was a bit objective to that. And I said, well, whenever I can, I advocate for the women's rights and for the rights of women, but I can only go so far because I can't totally see the world through a lady's lens. So although I'm helpful and I try to be helpful and respectful, I can only go so far because I keep trying to learn that lens and trying to get better and better at it and listen to those people around me who can guide me in those directions. So it's the same kind of things that really apply around Aboriginal health.
Yeah, I see. Thank you. And I'm thinking about that the need to do your best to try to sort of put yourself in somebody's shoes is, really important. And I'm just thinking about that, sometimes some of the uncomfortable things when non-Aboriginal people are working in First Nations health is actually facing up to and, acknowledging historical injustices. Not that one would need to do that in the clinical setting and, do a piece before you start, working with a patient. But, it feels to me like it's important to have done some work and some reading and some education of yourself in order for you then to be able to understand what might be behind some of the things that are going on for a patient that might be in front of you. And I'm thinking about stolen generations, forced removal, disconnection from culture, all of that, the historical, ban, stopping people using language, all of that. And, of course, we know that some of these historical injustices are not just historical. We see now child removal rates, are high, incarceration rates, deaths in custody. So I'm sort of reflecting a little bit on that, the necessity to sort of face some of the, really potentially distressing history. Any reflections on that?
Yeah, first of all, when you first started talking there, I couldn't help but to smile because what you're saying is absolutely true. So mostly it's about us learning about us rather than learning about other people, isn't it? It's about learning about our little idiosyncrasies and our ways that we view the world, and that's totally, it's a big part of it. So thanks for bringing that up. And then there's the part that I think a lot of people might not necessarily realise. People think, oh, that stuff's way back in the past, and I know people and I have patients who are part of the group, and I think it was in the early 70s still, it might have been late 60s at the latest. Whereas if an Aboriginal child was in school, in a classroom with non-Indigenous children, and one of the non-Indigenous children's parents said, I don't want my child to be in a class with an Aboriginal kid, the Aboriginal kid would be forced to leave school with no other options. I mean, this is the stuff that's the legacy of the past, but it's still very present with people. We have people who are part of the stolen generation who are really some people are really struggling with issues about themselves. They know they have Aboriginal heritage, but they don't. Some people have told me, like, I don't really feel like I'm Aboriginal, even though I am, because I missed out on culture, I missed out on all these things, and what we need to do is embrace those brothers and sisters and bring them along the journey with us in the same way that we do with our non-Indigenous brothers and sisters on this journey of learning to be better in the clinic, those kinds of things. And we really can turn this stuff around. I think that there is good evidence these days that, for example, about the training. When we train school teachers in cultural training, cultural appropriate responsive training, whatever we're going to call that, the rate of suspension of Aboriginal children in the schools goes down dramatically. Whenever we train DOCS workers and those kinds of people around Aboriginal cultural training, the rate of removal of children from their families goes down significantly. And it goes on and on. Police arrests of Aboriginal people goes down significantly. And I think what we're doing there, we're starting to change the lens of those people. So instead of seeing the problem as it initially presents to their eyes and their initial emotional response, they're starting to think about it and think, oh, this might be what I quite think it is. I wonder if it's this. And then they look further and go, oh, it is. And I've got a responsibility here. So we certainly can make those positive changes.
Yeah. That's reminding me of a session you did. I think it was way back in 2020, which is it's a while back now. But I think the annual RACGP conference, you were doing a bit of a session, and you talked about structural racism as being one of the big things to tackle. And I'm sort of thinking about some of those behaviours that you just sort of mentioned. Those really negative behaviours as sort of an expression of that structural racism.
Yeah, and I think, in primary healthcare, we're perfectly placed to make differences there as well. I often talk to people about, in that institutional racism setting, about the Dharma, the discharge against medical advice. So someone comes into the emergency department and, and I've had this with my patients as well. They come into the emergency department, they're happy to have treatment, everything's going okay. Suddenly this environment is so toxic, and then they go, I want to leave. And we, as doctors and nurses, we say, sign this form. If you leave the front doors, you could drop that out the front, but sign the form anyway. And they do that. So what is it that someone's happy to come in and have treatment, but something about this environment is so toxic that they would rather risk dying out the front than stay here? That's the trauma of racism. That's how powerful it is. So people make that decision. And then there's the stuff that sure, we can't change every system all the time, but just to use another example, one of the old elders in my community who's now passed, is a beautiful lady, I really miss her. I got a call to do a home visit for her, and she had a really significant cellulitis on her legs, and I wanted to have intravenous antibiotics. And she said, oh, Peter, I don't want to go to hospital. And there was a couple of people in the room she wouldn't really talk much about. I said, if I pop by after work, can we have a conversation about this? She said, oh, please do. And same thing, cup of tea again, having a bit of yarn about things. I said, Aunt, what is it about the hospital? She said, well, last time I was in there was when I delivered my last baby, which was like, 40 years ago or something. And she said, I was isolated and treated so badly. All the other ladies who were having their babies got to be in a room, and I could hear them talking about their babies and their pregnancy and all that kind of stuff. And I was out on the old veranda where there was no air conditioning, those old slatted windows that you can't really close. And she was the only one out there. And she said, I just felt so embarrassed. And anyway, so I talked to her and said, if I can change that for you, will you go to hospital? Because I don't want you to end up in intensive care with a sepsis. And so she had enough faith in me to go along with that. Now, what I did was I gave her my card with my mobile number on it, and I said, if anything at all happens that you're vaguely uncomfortable with, don't sort of get into a battle or don't have a confrontation, just call me. I then, on the referral, stapled my card to the referral, and I said on the bottom of it, if there's any challenges or anything happens that you're not quite sure about to the medical team, please just call me. And then I rang the emergency department and spoke to the triage nurse, who just happened to be an amazing human being. And I told her Auntie's story, and she said, oh, we'll look after it. And then I had to go away. I had an overseas gig straight after that, and I didn't get any calls. And then when I came back, I called in to see her and see how she was going, and she said, oh, it was really embarrassing. I thought, oh no, what happened? She said, you know, they treated me like I was some kind of queen. They were so nice and kind to me and loving. I just felt like I belonged there, you know. So this is the stuff that we can change. We just got to think about how it's going to work for our patients and how it's going to work within this system. But we can make those changes and change someone's outcomes. Now she might have been someone who just pushed on until she, you know, got so sick she couldn't not go there, and her end result might not have been the same.
Yeah, absolutely. Yeah.
Yeah.
So you're going that extra mile and, you know, taking really deep care of people.
Yeah, and I think that's a large part of what it is, isn't it? It's about advocating for our patients, you know, and I often think back to like, and sometimes you feel you have a choice, and sometimes people can walk away and others can't. I remember thinking about for medical students, you know, if the team on the medical rounds, the doctor at the top is quite a bit racist, and there's a patient in the bed who they're being racist to. As a student there, you think, oh, at this moment I have a choice. I can intervene and advocate for the patient, or I can sit back. But for me, I know I can't, because if I sit back, it's going to eat me away from the inside.
Yeah.
So I have to make a choice to advocate for the patient, knowing quite well that it could damage my career. And given those kind of people who, you know, who are racist heads of teams, it probably will damage my career. But sometimes you just got to think about the humanity in what we do, and at the end of it all, that's why we're here, isn't it?
Yeah, absolutely. And hopefully the more education that medical practitioners and their colleagues are given, and that they seek out for themselves, will end up in a world where we don't have those racist senior people to have to deal with.
Absolutely.
Peter, I think we've pretty much run out of time, but unless there's anything that any remarks you'd like to close with.
Look, again, you know, thanks for the opportunity. I hope the event goes well and everyone has a great time and learns heaps of things. But I think the most important thing is to don't be scared to take a step forward. And as I say, if you approach things in a respectful way, everyone's going to win from that.
Fantastic. Peter, we're very grateful for you making the time to have this conversation. Thank you very much, and all the very best.
Thanks, Matt. Appreciate it.
Wonderful. So when I was talking with Peter, he was really keen to come down and join us face-to-face, hopefully in real life at some stage. So that hopefully is something that's in our future. One thing that I just wanted to mention before we go to Tanya Dalton is that on the agenda, we have Kath Travis, who is a Stolen Generations survivor. Now, Kath is currently involved in sorry business, as is the Watherong community that she's part of. So I just wanted to note that Kath won't be with us today, and note that our thoughts are with Kath and the whole of the community, the Watherong community. So now I'm going to invite Tanya Dalton up to the stage to have a bit of a chat with us about social and emotional well-being. She's a wealth of knowledge about this subject, and I'm really honoured to have Tanya here. So welcome, Tanya.
Thank you, Matt. Firstly, I'd like to acknowledge the traditional custodians of the land, sky and waterways where we are calling in from today. For me, it's Wadawurrung country near Geelong. I would like to also pay my respects to elders past and present, and for those that are taking that journey. My respects to all of those who are joining us today, and welcome the sharing of knowledge and the conversation that we're about to have. So, which way? This way? No, other way. Cool, thank you. I'd just like to add a few things that Peter touched upon, Professor Peter O'Mara, and just explain a little bit about holistic health and what we mean by social and emotional wellbeing. It does have an evidence base. It has got 9 guiding principles. So I'm happy just to walk us through that, then let Cherie do her speech after me. So the holistic health through Aboriginal people touches on every aspect of their life, their spiritualities, their ancestors, their country, their whole identity as First Nations people. This has been around since 1989 and adopted by many. Social and emotional well-being. Oh, I'm trying to... Sorry, I've just... Oh, there. Social and emotional well-being is also holistic and touches on these and touches on the principles of holistic health. I know that sometimes this terminology has been appropriated in other ways as a sort of term used, a fancy term used for mental health. It is more than that. And the thing that I wanted to probably say is that there is no equivalent in mainstream for what First Nations people mean by social and emotional well-being. And that's why I sort of chose to, all right, let's go on this journey. So the guiding principles are Aboriginal concepts of health are holistic, encompassing mental health, physical health, cultural and spiritual health. And land is central to our well-being. Crucially, it must be understood that we live in harmony with these things. So if something is out of whack, then we don't feel well. It impinges on our well-being. And this guiding principle relates to what we call our cultural determinants. So that slide I showed you just before, cultural determinants are all laid out in the middle of that diagram. That diagram was done via a national consensus and roundtables to actually develop the evidence base for what social and emotional wellbeing is for First Nations people. It also has been written about, and more prolifically now. So the next thing is the centrality of family and kinship. And we just don't mean Aboriginal people are generally collectivist. So our families and our kinship networks are very important to our actual well-being, not just to our physical health that we could come in. It impinges on all our life. And again, that's another cultural determinant. So it's a strength of ours, or that's how we see it. Culturally valid understandings must shape the provision of services and guide assessment, care and management of Aboriginal people's health. And that touches upon a little bit what Professor Peter O'Mara was talking about having that yarn, knowing that client, that patient, understanding, opening up, seeing what's important to them, what other things could be impinging on what's going on for them. And again, that's another cultural determinant. And also recognising that First Nations people have great strengths, creativity and endurance, and a deep understanding with the relationships between human beings and the environment. And that's the holistic concepts for First Nations people. Another cultural determinant is that to understand the diversity of First Nations people, and that there's numerous groupings, languages and kinship. And that's why we introduce ourselves or the way we do. I, for instance, am a Wadawurrung Gunditjmara woman, and I relate very strongly with my country and my kinship of that country. So when Aboriginal people and those that are lucky enough to know their country, that's how they will introduce themselves, or others, because of the historical determinants that Matt touched upon, and so did Peter, may be still on their journey and may never know exactly where their roots come from, but they may relate to a community in that stead, but they are still identifying as First Nations people. So this principle touches upon the trauma and loss of what happened with colonisation, just that I touched upon before, and it talks the historical and the determinants of social and emotional well-being. So and this trauma has intergenerational effects. So we'll probably touch upon that a little bit later. I'm conscious I've got 10 minutes, so I'll just keep on plowing through and hopefully we'll get some questions. The other thing is what Matt and Professor Peter also touched upon was about the racism, stigma, environmental adversity that is felt by First Nations people when they're entering into institutions, when they're going into certain settings. And the medical setting is one of those settings, the primary health setting. So it's about how to improve those environments and what can you do in those environments to improve the mental health and wellbeing. And it's about maybe using culturally validated tools and assessments if it's at your disposal, and educating yourself as to what they are. The other guiding principle is the human rights of Aboriginal people must be recognised and respected. So this is a First Nations, a United Nations charter, and Australia signed on in 2009 to this. So it's a political determinant is what we're calling it for social and emotional wellbeing. So I suppose it goes without saying that our health is all, it's not just the biomedical model, it's a biomedical, social, cultural, environmental model, if I can be so bold to put it in those terms, that is very broad. But I just thought that when we talk about this, we expect people that they know what we mean by it. But that's why I thought, well, I'll just run through what are the guiding principles and what does the actual model look like. And that framework can be found in several different articles if you want to read about it, if you want to talk about it. We only use this model in a strength-based and educational approach too. So I think that's probably all that I've got to say about social and emotional wellbeing on this instance, but I'm happy to take any questions after Cherie has had her talk.
Wonderful. Thanks, Tanya. And yes, folks, we really do encourage you to ask some questions. It's not every day that you have First Nations experts with this level of experience and understanding and history in front of you, so do use that. And I'm also reflecting on Reconciliation Week that's just passed, and the theme there was be brave, make change. So don't be frightened of asking some questions. The chat is open. And now I'm going to welcome Cherie Lowe. Really excited to have you here, Cherie. So fantastic to have you here, and we'll throw to you to share some of your thoughts with us. Thank you.
Hello, everybody. Thank you, Matt. I too, it's nice when you kind of get a segue and you've got some helicopters flying directly over you, just to kind of test the sounding barriers. But I'd like to start also by acknowledging country and acknowledging the Wurundjeri people of the Kulin Nations, where I'm dialing in from today, or better known as Naarm, or in Melbourne. I actually live in Wadawurrung country there in regional Victoria in Ballarat, and have very deep connections to the southwest, where my mob is from. I'm a Djapurrung, Peekwurrung, Kareewurrung woman from the southwest, or for those kind of a little bit more familiar down that way, Gunditjmara country. I lived in Wadawurrung country for the majority of my life, so I've kind of really lived in that southwest regional Victoria strip. In saying that, I would also like to extend my deep condolences to the Wadawurrung community on the passing of their matriarch, and just acknowledge the grief and loss which Kath and her family are going through at the moment, and the grieving community of Waterong. I'm really excited to have a conversation with you all, even being virtually. Probably up until I started my role at VATCHO in July last year, I didn't really have a lot to do with GPs in particular, unless I was sick or accessing health or advocating health for some of my family members who I care for. That was up until last weekend, where VATCHO hosted its first statewide GP conference. And so got to spend a couple of days having yarns and getting to hear from different perspectives of that profession and the challenges as being ACOs working. In particular, these ACOs were working in our these GPs were working in our ACOs, and having some really interesting conversations around trying to kind of bridge that knowledge gap and transferring of different knowledges that we have. So knowledge and sharing that, particularly from a cultural safety perspective, and being able to understand a little bit deeper from my end the working environment which our GPs in our broader kind of health practitioners work within. I work for an organisation which is called the Victorian Aboriginal Community Controlled Organisation, or VATCHO. We're the peak body for our Aboriginal community controlled health organisations, or our co-ops, or our medical services, health services that people may or may not have a relationship with. So we have 25 ATCHOs across the state which form our membership, and we have another 7 organisations which are Aboriginal community controlled as a part of our membership base, but they don't have a medical attached to them. We've been in operation since 1996, and so last year we were celebrating our 25 years of operation. We came into existence because of the need of that collective voice. And so one of those key kind of values and perspectives from an Aboriginal perspective is very much coming from a collective as opposed to individualism. And I think that you can see that when you work with families and with communities, that often we speak in collective tone, we, us, but also community. We very rarely kind of speak in the tone of I, me. And I think that that's a really important part when working with patients in particular, about understanding how this individual interconnects with a whole range of aspects, whether it's from a personable aspect or a connection aspect. And sometimes being able to unravel that can help understand some of the challenges in which people may be presenting in. Show is the Executive Director of Social and Emotional Wellbeing. So a lot of what Tanya spoke about, so thank you for that lead in around the foundational understanding of what we mean when we talk about social and emotional wellbeing. But it probably goes a little bit deep for my role, which came specifically out of the response to the Royal Commission into mental health. One of the key recommendations from the Royal Commission was to establish a centre of excellence in Aboriginal social and emotional wellbeing. The commission, in that process, were able to hear stories from Aboriginal people, Aboriginal leaders, Aboriginal communities around the challenges that they face in navigating the mental health system. It's disconnected, it's fragmented, it's challenging because it's a very Western clinical approach that doesn't recognise what Tanya just spoke about, social and emotional wellbeing, and the importance that plays in an Aboriginal or First Nations person's holistic sense of health and wellbeing. It also called out discrimination and racism, and how the system made people feel lesser, and often meant that people were accessing service far more at an acute level as opposed to a preventative kind of prevention model, early intervention type access. So what does the centre do? So the centre is new. We launched it nearly a month ago, and focuses on building the cultural safety of the sector. What drives us and what our focus is to ensure when Aboriginal people are accessing services that there's no wrong door. We know that many Aboriginal people prefer to access services at our Aboriginal community controlled health organisations, but it's important to note that sometimes our services don't provide all of the care required for somebody's healing. They may need to access mainstream services from a hospital, from other GPs, from specialised services. And it's important that regardless of where people seek help or reach out to start their journey of healing, is that there's no wrong door, and that all services that we access as First Nations people are culturally safe and of high quality. So the centre is centred around that. It's about building best practice and bringing that to the forefront. It's around building the workforce sector, one for our over 300 workforce that are working specifically in Aboriginal social and emotional wellbeing, but also for the wider community, in being able to understand the concepts of cultural safety and being able to understand the importance of that and what that's trying to address. Because I think that sometimes when we talk about cultural safety, that it comes with a lot of challenge and a little bit of resistance, because as a nation we still struggle to reconcile with our history and our hidden histories, which are a little bit uncomfortable to speak about. And I'm sure that many who are listening have kind of reflected on those histories as we've celebrated Reconciliation Week, but also acknowledging the 30-year anniversary of the Mabo decision, because they're quite significant parts in our very young history as a nation. And I liked what Peter said a little bit earlier, is that often when we talk about history, we think about it in a, many centuries ago or hundreds and hundreds of years ago. My dad wasn't born a citizen in this country. He was born in 1954, First Nations person, and grew up at Framlingham Mission. So 67, as people and not flora and fauna. But it wasn't until the Mabo decision back in 1992 that we, as a nation, recognised that Terra Nullius wasn't in fact an accurate reflection of our histories. And it's really important to acknowledge that, one, to challenge the history of law and the legal system in which rules us as a nation. But it's important for us as Aboriginal and Torres Strait Islander people, because it reinforces the concept of sovereignty. And sovereignty as Aboriginal people, we need to acknowledge that that was never ceded, and that we are sovereign people. And although we work and operate in a very contemporary context, we still hold true to those cultural values and cultural customs and connection to lands and waters, which make us well and which make us healthy. And being able to reconcile with that as a nation is one of the hardest things for us to do. The things that we can do in building relationships and building partnerships and starting to understand each other better, and different points of view and different perspectives and different experiences. But one of our greatest challenges for this country is to reconcile our histories. You'll see is that until we do that, we will still see First Nations people present in our healthcare system with really chronic health needs, because they're kind of navigating and moving through that doesn't really recognize their cultural needs. They're moving through a system where we think about it that we treat everyone the same. And that's not to say that we don't treat everybody with respect and with dignity and compassion and empathy, because everybody wants that, right? Everybody needs that as a human, their human needs. But if we don't see people's cultural needs, whether it's First Nations people or whether it's coal communities, we're never truly meeting them at where they need to be. And it's an important aspect to understand, because as Tanya mentioned earlier with the Sub wheel, when we're meeting people at their cultural needs, there's a real interconnectedness of aspects of what's going on underneath the surface. We all have a culture. First Nations people, Western people, Anglo people, everybody has a culture. And that's important to recognize as well, because when we understand ourselves and understand our culture, we also then can understand how that plays out in wider society. It's sometimes harder for people to recognize their culture because it is a part of the dominant culture makeup minutiae that we have and see. But I think that that's a real essence to solving and addressing some of the health gap that we have. And I'm really keen to explore and have conversations with the people in the room around cultural safety, around SUB. It could even be a little bit broader, around our Aboriginal community controlled organisations and the importance of those in a healthcare service system. Because I think that what we're starting to find out in pockets, that when we really lean into Aboriginal ways of knowing, being and doing, and having a really kind of collaborative approach to healthcare and health solutions, that we see far better outcomes. So I might leave it there, Matt, because I can yarn, but I would really keen to hear from the audience and just encourage people. It's a safe space. Ask the burning questions, like you said. It's not often. You have panelists, First Nation panelists, to be able to kind of ask questions of. And I think that anything that we can do to help your understandings or improving practice, then that's what we're all about.
Wonderful. Thank you, Cherie, for that. And thank you, Tanya. We do have one question, so I'll just jump into the question that we have, but I'd sort of reiterate Cherie's invitation to ask the question. There aren't bad questions, so do use the opportunity, please. Otherwise, I've got heaps of questions that I can ask, and we will go for the whole time, so that's going to be fine. But the question that somebody has asked, Cherie and Tanya, is about the URUK Justice Commission, which is begun the truth-telling process. Is there a need or emerging demand for additional support to people being re-traumatised through this process? And I might just tack on to that question in a way. I think the reparations scheme for stolen generation that is now active in Victoria probably also is something that can bring up issues, experiences, history for First Nations patients that might be fronting up to mainstream services. I suppose we can probably generally assume that the ACHOs are all over this because it's absolutely their cultural bread and butter, if you like, but we don't necessarily expect that mainstream services will be all over this, but we can support them to address that. But over to you, Tanya and Cherie.
I'm happy to go first, if you like, Cherie. I think talking to the URUK truth tellers and truth receivers, they have said that they've been out in community And what they've found is they were going into communities and just as a preliminary doing an information session, and people were coming along and were sharing their truths, and they weren't expecting that. And so other people were being triggered in community along with them. But I think we need to go back a bit and talk about the complex trauma of these people that are brave enough to come forward. They're not telling their truths for therapeutic recovery. They're telling their truth for justice. So it's a very different sort of way when you look at the mental health of people's well-being. Usually you're taught that to come in and tell your truth or to tell your story is therapeutic. In these settings, it's not. The whole drive is for justice, and it's at their expense at a lot of times. So, and then that has that knock-on effect, as I said, and as Cherie touched upon, because we are collectivists. So it impacts on their families, it impacts on their communities. So it's really important that if they're going to seek some sort of supports, that you understand what's gone on. And it's not about opening them up and wanting to hear everything. It's being led by them, because they will tell you what they need for you to know in order why they're seeking your supports and your services. But because of complex trauma, you cannot open somebody all the way up if you cannot then help to not trigger them or for in their recovery, basically. Because I suppose that's the things that we have found. So we've been supporting by using some First Nations psychological supports, and they, when people are triggered, just ensure they have supports around them. So if somebody's coming to you, just ensure they have supports around them. What is their family supports? Have they felt this way before? All of those sort of things is very helpful to them. Just give them a quiet space and a cup of tea, sit with them, let them tell you what they need to tell you, and be led by them, I suppose, is some of the things that we've been talking about with Juruk, and also with reparations, because again, reparations will never go towards, and it's very divisive, and it can be very traumatic for communities when we talk about these things, because no amount of money will ever compensate for some of the trauma that these people have been put through. So I suppose that's the first thing I wanted to put out there in working in this space at the moment, is that, they're first and foremost, and that's what self-determination means in a collective sense, is that they need to determine what they need and also where they're going to take you when they're telling you their story. And it's a privilege, basically. And I think that's what Professor Peter touched upon. It's a privilege to walk in and work with these people. So, yeah. Cherie.
Yeah, agree with all those points, Tanya, and probably would only just add is that the question's a really good question, and it's something that we've thought about a lot. It's something that we've advocated a lot with the Department of Justice, in particular around repatriation, and they have a model of care that wraps around that. But our advocacy is to point people in the way into the direction of mental health services and those types of things is great in theory, but we also know that those services are often culturally unsafe. So it is been an ongoing conversation around the importance of knowing that we don't know, how that this is going to impact people telling their stories. As Tanya mentioned, we don't know what is going to trigger people's trauma, and it can be some of the most simplest of things. We were having a yarn with an auntie last weekend at the GP statewide forum, just having a general chit chat. And around her family cooking on the riverbanks of the Murray River where we were on country, and something happened in that conversation that triggered a trauma for her that she shared with collectively in that group, but nobody in that room was prepared for that. And it was it went down a very different path. We have things in place at the back end of that, of supports that you can access and those types of things. But I think having that front and center and thinking about that is a really important step in the model of care, of knowing and understanding, in particular, some of those really historic, deep, very deep traumas can surface in some of the most simplistic ways. Asking people how many children they've had, asking how you ask people whether they're Aboriginal or not. They are fundamental questions that help deliver high quality health care. But even in that way of without asking those questions, without having a relationship or some sense of trust in that way, or confidence of knowing where that information is going to go, you just kind of don't know. So I think that being able to understand people's stories and prepare as much as we can, but we can't completely prepare for the unknown because we don't know. But it is definitely on our radar of making sure that we put as many things that we can in place to protect our elders. I know Uruk has done that in the way of how they've set up the hearing processes for the elders at the moment. But it is a little bit of a wait and see.
Thank you, Cherie. I'm just looking at some of the questions, and there is a question here about how would you recommend GPs upskill? Is there a specific program? I suppose I'd just like to open before throwing to you, Tanya and Cherie, I do know that there is some cultural awareness training that's available, and sometimes that's online, sometimes in person. And one thing that we're really happy about at Western Vic PHN is that we've been working with most, I think 6 perhaps of the 8 ACCHOs on the lands across which we work to develop some cultural awareness training that's specifically aimed at general practice, both GPs, practice managers, practice nurses, front of house reception staff, and the ACCHO teams will be delivering that. So there'll be a sort of a localised to country focus of that, because sometimes, cultural awareness training could be focused on communities from Northern Territory, which, there are some similarities. But, as we know, if we look at the map of all the countries, there's huge diversity, enormous diversity culturally and language-wise and all of that. So I suppose I'd just note that. But I suppose as far as social and emotional well-being, can you tell us about any training, upskilling opportunities that you're aware of? And if you're not, then that's a job for us to get onto at the PHN. Cherie, perhaps?
Sure. So I think that there's lots of ways on how you can upskill. I think for me, when I think about learning, it comes in a few different layers. So one, building knowledge. So building and developing a knowledge base. The other component to that is skills. So then developing and accessing. The third part to that is then being able to put those knowledge and skills into practice. I think that in this space, there's a couple of points, and when I deliver cultural safety training, call this out for our participants, is that this is an ongoing. Sometimes people freak out by that and go, "Oh, there's not an end because we're built and wired that way. There's a start and an end, right?" This is ongoing, just like any learning, any aspect to your profession. The more you do it, the more you become proficient, and the easier it comes. And so this is nothing dissimilar in that way. But you need to build a foundational knowledge, and that can be done through a whole range of different ways. Batcho deliver cultural safety training, but there's many First Nations businesses that deliver cultural safety. I think it's important to have aspects that focus on cultural safety, which is really about unpacking and understanding yourself just as much as it is about understanding the cultural other. It's also about looking at systems and structures and addressing racism. So that's how cultural safety differs to, say, cultural awareness. But it's also important, Matt, just as you have said, is to really understand the local communities in which you're working with, the local people, the local knowledge, the local histories. And so, say, for example, for me, who on Ballarat in Wadawurrung country, there's some really unique things about that place. We have 4 orphanages, so we have a significant population of stolen gem. It is the location of Ballarat has been a really transient community and gateway to other communities. So, mobs come and go and those types of things. And as a from a service delivery point of view, it's important to understand that. So from a stolen gems point of view, like around that model of care that wraps around that person, but also knowing that the relationships and building relationships that it may be harder because people are kind of coming and going, tracking down. They might stay for a little bit and go, and those types of things. So continuity of care. So understanding local areas is really important. But the other part is around who you surround yourselves with and how you test your knowledge and putting it into practice. So having connections with First Nation people and being able to create spaces to have a yarn and test that, because how else he is going to know whether he is doing it right or wrong. So it's really important to have access to Aboriginal kind of not so much supervision as such, but having those voices and connection points to be able to debrief with and be able to test things with. And as you kind of put things in practice, you're not going to get it right all the time. I know that that's another thing that, because we kind of strive to do our best and to be the best that we can be. But sometimes we are going to ask the wrong question. Sometimes we're going to make some assumptions. The important thing is to not let those hiccups along the way stop the process of growth. So I think that there's many ways of doing that, but it's not just one way, and it's not I'll do X, Y, and Z and then I'm done and sorted and then I can keep moving. Is probably my tips in that space. And after this, Matt, I can forward some other providers that you can share out to the network of people that may to access further learning and development.
Wonderful. Thanks, Cherie. Tanya, anything you'd like to add there?
I suppose IEPA has been doing this, identified this in the mental health space in 2010. And I think that part of it was this. It is a journey. It is about people's experience and exposure, as Cherie has said. And I suppose that we do need foundational knowledge. So strong social and emotional wellbeing is an organisation that I'm a part of that's only been there since 2020 now, I think. And what they're doing is doing some of these conversations, identified needs, having that yarn if they don't have or haven't built those relationships or networks, so they can, one, impart some of the knowledge, but also tell them how to go about making some of those connections and things like that. I think the other thing is that to do some of your research, there is, Cherie is part of a Centre of Excellence now that has resources that you can go have a look at and sort of share. I'm also part of a Centre for Excellence on Suicide Prevention that has a lot of social and emotional wellbeing tools and assessments and everything there too on those websites, and they're invaluable. But as Cherie said, it's the diversity and what the patients are looking for, I suppose. But it's about skilling yourself up with as much knowledge and feeling comfortable about having conversations and clarifying with people, because as Aboriginal people, we're storytellers and we talk in circles. We don't talk real direct. So it's about understanding where they're coming from. And I suppose it's that level of engagement is the first and foremost in the building of trust. Is what I would say to people. And yeah, when they come into new areas or where your practice is, get to know what your Aboriginal community looks like in that community, in that area. So I'm now based in Geelong. My nan was born on Franlingham Mission too. Cherie and I are related through those connections. But also in Wadawurrung, there was 13 orphanages in Geelong. So how their echo was built was from those Stolen Generations community all coming together so they could form that community. Now, you know, and again, transient, we have a big prison population here, so families come and go because we sort of touched on a little bit about some of the social determinants that impact on our people and also impinge on their health. And so, yeah, so it's worth noting some of that and just, you know, start to know, have those conversations around where you're living and what the Aboriginal community and Torres Strait Islander community looks like in your area as a step one.
Yeah, thank you. I'm just reflecting that you know, over the last few years, there's been such a growth in the amount of books and histories and sort of and social history and sort of contemporary writing from First Nations people. So, you know, if you pop into the bookshop as well, there's a wealth of, you know, fantastic learning that you can get your hands on there. And, you know, certainly on the web, there's plenty of resources too. And I'm just wanting to make sure that I note that RACGP has a great resource called 5 Steps Towards Excellent Aboriginal and Torres Strait Islander Healthcare. So it's quite simple. It's a pretty succinct document, so it's not a tome. And it talks about preparing your practice. And I think in the questions, someone's talked about that when someone, you know, says that they're a First Nations person, there's nothing in the practice about how to connect them to an organisation or how to help them for any documentation. But you know, that's probably about the practice doing the work to prepare itself, and, you know, so that when people do say, yep, I'm First Nations, they then know what that means as far as how they can provide best healthcare for that person and know what else is there outside and surrounding the practice to support that person if needed. Asking the question is, yes, jump in.
Can I just jump in about, you know, when somebody does identify, when you ask that identifying question, it's about also knowing why you're asking the question. If you're only asking it for data, you're actually letting the First Nations person down because the expectation that you build when you do ask that question and somebody identifies as that, they're sort of thinking, okay, well, what does this mean for me? Am I going to get now a GP that is going to actually understand when I say that I cannot make appointments on this time because I have roles and responsibilities or cultural obligations or things like that? Am I able to be open about that? Am I able to be open about what is actually impinging on my physical and mental health, and sometimes that I haven't been able to follow through because other things are taking priority that may not be understood or may not be able to, you don't have that general conversation when you're going into a practice. And I think also that it's the burden when we talk about social determinants. It's the burden sometimes of people will prioritise their health and that by if they've got no money. So that's why sometimes if you're not doing your health plans and that sort of thing, and being able to charge bulk bill them is also very, very good. And because resources are shared, and they're also usually like money. Sometimes you have to prioritise these things, whether you need to go to the doctor or whether you don't, or wait until it gets worse, or go to the emergency rather than, be able to access primary healthcare where you can really have those relationships which are invaluable to our people's holistic health. So I think some of those things, and by writing Close the Gap on the top of their prescription, so they can get it at minimal costs rather than $30 if they've identified, these sort of things. Just, what can your practice do in order to make you accessible and for First Nations people to be using your service?
Thanks, Tanya. Talking about closing the gap, there's a question I have about, I've heard from some First Nations healthcare workers that I've spoken to, over the last few years, who sometimes are a little bit critical of closing the gap because it has sort of quite a deficit sort of a focus. And I'm interested in both of your reflections on, as healthcare workers, whether, we don't want to be Pollyanna about it and ignore reality. So, those closing the gap targets are real, and they're things that, it would be, good to make much more progress on than has been made to date. But I'm thinking about both of you talking about social and emotional well-being as having a very positive, strength-based sort of lens. And I'm wondering about your, oh, there's a ghost. I'm wondering about your reflections for practitioners about trying to keep that positive regard and positive lens when, in that social and emotional wellbeing framework. Cherie.
Yeah, I was distracted by the person coming in the door.
Yeah.
Sorry about that, Matt.
No problem.
Tanya, did you want to go first?
I was waiting for you. I suppose, look, a lot of the funding is determined by that deficit approach, right? And so that's the burden of disease, all of that sort of thing is how it's measured. But in the practice of working with First Nations people, I always work from the strengths. What have they got in tow? What are their supports? All of those sort of things is my first what's going on with them at the moment. All of those sort of things, I start with that and build on that. So it's not all about, it's, that burden of disease stuff. We're all aware of it and we all know that it's there. It's just in listening to their story that we can piece together, okay, what are the impacts of this that's having on this person, basically? And then where do we go from there to build them up, to make them better, to support their well-being, I suppose is where the way I come from. And it is frustrating because you have to turn everything on its head, but once you start working in that manner, it's quite easy. So it is.
I think the other question around closing the gap is, are we measuring the right things?
Exactly.
As well? And are we, like what you had mentioned, Tanya, are we investing in a way to close the gap? So I presented a couple of Fridays ago now with Pat Turner at Big Steps. And she just led off with the massive deficit in investment within Aboriginal health. So I guess to think about it, the the nature in the title, closing the gap, kind of feels like that once we close the gap, that we're all sorted and done. So I think that
Yeah.
like leads true to that deficit kind of language. But it is around, if we're addressing and looking at closing gaps, what are the fundamental aspects to addressing that? And then all roads in that aspect point back to self-determination and Aboriginal-led ways of knowing, being and doing. And so it is about, yes, investing in, but it's about being able to create solutions that are led by Aboriginal people, that are supported in a broader context with their why what broader kind of community partners and relationships. But at the moment, it does feel like it is a bit top down and imposed, and we talk about it at this level, but on the ground level, what we do see is the best solutions are local place-based solutions, which really center around Aboriginal communities kind of leading and having a voice in being able to determine what those solutions look like for them.
Yeah.
And that's across all the domains. So whether it's an education program, whether it's a health program, whether it's an employment program, when it is grown from the centre of Aboriginal ownership in that, then the likelihood of success and buy-in is far greater. And at the moment, that is still a bit unbalanced in how we're looking at addressing and solving the disparities.
Yeah, thank you. One thing that occurs to me is that we now have in the National Aboriginal Torres Strait Islander Health Plan 2021 to 2031 a really sort of an unambiguous and strong policy prescription that actually aligns with what you've just been talking about around strengthening the community controlled sector, self-determination, First Nations leadership, honouring Aboriginal ways of knowing, being and doing, building up and strengthening the First Nations workforce and growing that, and underpinning everything with a strengths focus. So I don't know, I feel like there's a cause for optimism in that the federal government, you know, the health bureaucracy seems to have listened, because that new policy is sort of, you know, more, it seems like it more reflects what we're hearing from First Nations people, you know, who aren't at those very high levels, if you like. So that sort of seems to be connecting up, which is a positive thing, I think. And I'd be interested in your views on that. We've only got a minute or so left, but if you want to say anything about that or make any closing comments, I'd be really grateful.
Go, Cherie.
I think that from our perspective and from VATCHO's perspective, that we hold great optimism around the movement going forward. The more we partner with our state and federal colleagues doing things differently, the greater impact that we have. So we are seeing some really great wins in that way, and really changing the nature of relationships. So I hold a whole lot of hope. Generational change is amazing. I'm sitting here diving in from my son's dorm room, who popped his little head in at Trinity College, right? My dad would never have, in his wildest dreams, he didn't even finish, you know, first year at high school kind of thing. So when we think generational change and the strength of culture, and culture as a protective factor around that, there's a lot of optimism and hope on the horizons for Aboriginal people.
Thank you. Tanya?
I suppose, speaking from the Australian Indigenous Psychologists' perspective, that, you know, we're in this for the long haul and for the betterment of mental health practice and wellbeing for our people, better understandings. We're writing prolifically on this subject. We're pushing for more Indigenous or First Nations psychologists to come through to assist, to be those referral points for mainstream services, and to allow for that access for our people, for those choices, because they haven't had that, or the things that in the past have been to the detriment of a lot of people seeking support and seeking those sort of things. So the more we can get the word out there, the more we can share knowledges and share research and evidence and all the rest of it, the better. And so I'm very, very optimistic about the future. So I am about this. I mean, I can see the changes that have occurred within the 20 years of me being a psychologist, Firstly, when I used to go to community and that, they didn't even know what a psychologist did, basically. I remember coming and one person, he thought I was a psychic. So, and I'm saying, no, it doesn't work that way. We've got to sit down, we've got to have a bit of a yarn about this, and let's sort of a few things out, sort of thing. So yeah, so but now, as I said, I'm very, very hopeful. And I mean, we work in partnership with Nacho and with Vacho and with Guy Dewey, who is now the national one that's brought all the doctors and the mental health together. So I'm very, very hopeful.
Thank you, Tanya. So now I know that I've run over time, and people probably want to do a few other things with the little that remains of their Sunday, so apologies for that. So I'll finish with deep thanks to Peter, Tanya and Cherie for a really engaging session. Thank you so much. It's so wonderful to have your knowledge shared with us. Listening to First Nations voices is absolutely central to supporting First Nations health. So thank you very much. And I'm now going to hand over to Dr. Anne Stevenson to close, and all the best, everybody. Thank you.
Oh, thank you. Oh, thank you. That was so inspiring to hear from you all. I really want to thank you for taking the time and the messages of optimism for all of us, and this really challenging history that we all share, and we really hope that we can do better in the future. So I am drawing our second day conference to a close, and I really thank everyone for taking time out of their precious weekend to learn more, and we've learnt so much today. It's been really wonderful. So I am going to, I think Expert Events are going to spin the wheel to see who our first winner is for the 200 red balloon voucher. I think they're going to let me know. It's Shoshana Slattery. I think that's probably Cardinia Health. I don't know if Shoshana's here, but Shoshana, you've won the $200 red balloon prize for today. So well done. So secondly, your input and suggestions are highly valued and inform further education that we do. And I really encourage you to fill your evaluation at the end of today, and you will, whoever fills that in will go in for another draw for another $200 voucher. So I want to finish by just thanking all our speakers, all the organisers at PHN really do a huge amount of work in the background getting this all organised, and they've done an amazing job, and Expert Events with this portal, which once you get the hang of it, it's fantastic. Goodbye everyone, and enjoy the rest of your weekend.